All right, everyone, welcome back. Welcome back. We hope that y'all were well educated, had an opportunity for really frank, open discussions during the workshop, and are ready to continue on with our larger group gathering. We'll have two presentations before we break for lunch. The first is an update regarding our KICS Clinic. It's really my pleasure to introduce Dr. Bird Gilmartin. She is a general pediatrician by training and an associate clinical professor of pediatrics here at the Anschutz Medical Campus, the University of Colorado School of Medicine. She's the founding director of the new Children's Hospital Colorado Specialty Primary Care Clinic in affiliation with the KEM Center, the Kids in Care Settings Clinic. KICS serves children and youth in out-of-home placement, so that is foster care and kinship. Prior to coming to Colorado, Bird worked at Evanston Regional Hospital in Evanston, Wyoming, where she served as the medical director of pediatrics and chief of the medical staff. She currently serves as the co-investigator of the Pediatric Integrated Post-Trauma Services SAMHSA grant, working to disseminate the pediatric trauma stress care process model and to develop enhanced implementation strategies for trauma screening and treatment and referral in rural settings and adaptations for the unique needs of children in foster care. Bird served in the executive committee for the AAP Council on Child Abuse and Neglect, and in 2019, she was the recipient of the AAP Council on Child Abuse and Neglect's Award for Outstanding Service to Maltreated Children. And I'm really excited to hear the updates coming from the KICS Clinic. Truly monumental progress in a very short period of time. So thank you, Bird.
Thanks so much for having me. So like Susan said, I'm here to talk to you all about the KICS Clinic. So my two goals really are to share about what the clinic is and then also to share some initial data with you. So I like to go back to the beginning briefly and talk about how the KICS Clinic came to be in its current form. And our charge was to start a clinic that specifically served the needs of children that had been removed from their families and were child welfare involved. And we started by talking with people with lived experience. We talked to parents who'd had their children removed. We talked to youth who had been involved with child welfare. We talked to foster families and kinship families. We talked to child welfare caseworkers and nurse liaisons. And we also talked to national experts at other institutions. And it was pretty amazing across all those conversations that 5 themes really started to emerge across all of them. And those 5 themes were improved communication across systems, to have a coordinated and integrated place of care, essentially a one-stop shop, the importance of trauma-informed care for all parties, the importance of connection to mental and behavioral health resources. And then another theme that really pulled through is the importance of all of our patients and families being able to come to a place where they were respected and not judged and welcomed. And so we really used these 5 themes to build the KICS Clinic into what it is. So the KICS Clinic is a medical home, meaning that we see kids for their initial assessments after removal, but we also see them in an ongoing capacity for their well child care, for their same-day sick appointments, if they have a sore throat, for their follow-ups, to really try and build a longitudinal relationship with our patients and our families. We exclusively see children and youth that are in out-of-home placement, and we see all ages. And the one caveat I will say is that we will see families, like if we have a kinship family and they have their own biologic children and they've taken in family members' children, we will also see that kinship provider's biologic children if they choose to bring them to the KICS Clinic so that the family can stay together in a cohesive whole medical home. I don't take my children to different doctors, and we don't want our families to have to do that. We have integrated mental and behavioral health as part of our clinic. So we have a psychologist that is embedded into the clinic. We have a multidisciplinary team, which I'll kind of show you more on the next slide. We have coordinated access to our dental clinic to improve dental care access. Our primary care clinic at Children's Hospital has a really robust universal screening program that includes social determinants of health and development and postpartum depression and depression. And we've expanded on that to include screening for traumatic stress, screening for anxiety, screening for substance use, and also screening for both our biologic families that come to the appointments and the foster kinship family that attends the appointments. So we can kind of help meet needs for all family members. We really, really care about engaging with our patients' families. We want them at appointments. We want them included. We want to have relationships with them. And we will continue to see children once they've reunified with their parents ongoingly in the KICS clinic for up to a year to kind of be able to bridge that transition. And then we really strive to be trauma informed. So that's kind of what the clinic looks like. This is the multidisciplinary team that is part of the clinic. So we have pediatricians and we have a psychologist and social work and a nurse care coordinator and a community health navigator and a child life specialist and schedulers and medical assistants and nurses. And on any given day, any one of those team members might be the most important person for our patient or our families. And it is not always me as the physician for sure. I think most of our kids like our child life specialist the best. So when we look at which patients do we see, we really have two primary referral sources. The first one is the Arapahoe County Department of Human Services. We get referred from their intake teams, not their permanency teams, for new placements where a child's been removed of all ages. And that is the bulk of our referrals. But we also will take referrals from the UC Health, University of Colorado, Newborn Nursery and NICU for infants that were prenatally substance exposed that are going to discharge in an out-of-home placement disposition. The clinic is 2 sessions a week, so Monday afternoons and Wednesday mornings. It's housed at the Health Pavilion, which is Children's Hospital of Colorado's outpatient health building, so just south of main campus, and is kind of embedded into the child health clinic. We have a few special collaborations internally. I mentioned one of them already, which is our collaboration with the dental clinic. But it was identified pretty early on that our kids had trouble accessing dental care and the families had trouble accessing dental care for them. So our dental clinic holds appointments for KICS Clinic patients to expedite their access. We also identified pretty early on that a large proportion of our patients have developmental concerns and a myriad of reasons they might have developmental concerns, and that can be hard to sort out. We also know that access to those specialized development assessments can take 1 to 2 years, and our kids can't wait that long sometimes. So we have a fast track to see a developmental specialist who partners with a psychologist who has background and training in trauma, and they can fast track our kids in for those assessments. And I guess coming soon, we will have an association with the eye clinic that'll look like dental. We also have some external collaborations that we are proud of and work hard on. I mentioned the first 2 already, Arapahoe County and Chosen Quick. Well, we also partner closely with Colorado Access as the regional accountable entity that's responsible for Medicaid, which all our patients are insured by for Arapahoe County. We also partner very closely with the early intervention broker that serves Arapahoe County, Developmental Pathways. And we also partner closely with Safe Babies. So I'm going to transition now and share some of our initial data from our first year. And then I'll also share from Q1 of year 2. So we saw our first patient in May of 2023. And so this data is from May 2023 through April of 2024. We saw a total of 44 children, 42 of whom were in out-of-home placement. We saw children aged newborn to 17. Our referral sources were overwhelmingly Arapahoe County. We had one Jefferson County placement. We had a family who had Arapahoe County placements and wanted to bring another placement that they received from Jefferson County to the KICS Clinic, and we allowed it. We had 3 chosen, and then we saw 2 bio kids of kinship providers. We had 27 foster placements and 19 kin. And we saw 7 children across 8 placement changes, which was 17% of our population. We had a really high retention rate, which we were proud of 82%. So kids who were coming back after their first appointment and staying in the clinic. And we had a remarkably low no-show rate of 4.7%. And to put that in perspective, our general peds clinic at Children's has a no-show rate of about 13%. And the national average for foster care clinics is around 25%. So this is pretty remarkable, and I credit our social worker for this incredible outreach and work. So when we look at our main source of referrals, Arapahoe County, in this first year, they had 128 verbal removal orders. There was 25 of those that were not appropriate for KICS, meaning they were placed outside of the Denver metro area, or the verbal removal order was reversed by the judge at the adjudicatory hearing. So 67 out of 95 of those potential referrals made it to the KICS clinic, which is 71%. And I can tell you we have seen this shift, and we are almost at 100% now in year 2. We looked at substance exposure for our population specifically. We saw 10 infants that were prenatally substance exposed, meaning they came to our clinic from discharge from the birth hospital and were under 1. So it's almost a quarter of our population. We also had children and youth that were older than that newborn population, but where we knew that they had been prenatally substance exposed, but we were seeing them as a toddler, or where substance use for the parent was the reason for removal. And that was almost 50% of our population. We had 5 kids where we did not know what the substance exposure was. And we had 7 kids where we felt like there really wasn't reason to believe that there was substance exposure. So when we put all of that together, 71 to 83% of our cases involve substance use. I had spoken about our commitment to including the biologic family. One of the processes we have is that our nurse care coordinator calls every family after an appointment up to 3 times to try and let them know that the appointment occurred, what happened, answer any questions. And our social worker is calling on the front end to see if they can come to the appointment, send transportation if it's possible for them to attend. And so when we say contact success, that's really referencing our nurse care coordinators' efforts to call families. And you can kind of see it's variable, but we have a pretty high sustained rate of contact success with our families. And in almost every quarter, at least some of our families were able to attend in person. One of the things we're really committed to, and Susan spoke about this earlier in the presentation about early intervention and the importance of that, is making sure that our littles, our kids under the age of 3, are getting their early intervention referral and ensuring their connection to those assessments and services. So we saw 17 age-eligible children for early intervention. All 17 of them were referred to early intervention. We continued to see and follow 14 of those 17 kids, and 100% of those had their assessment, qualified for services, had their individualized family service plan developed, and were receiving services. And when we look at that and how that compares, when outside of KICS for families who are trying to get that service done, only 28% of them that happen versus in KICS 100%. And when the bottom slide of this is really access to the developmental and behavioral pediatrician, when there's been developmental concerns, we've been able to get our children seen by a developmental and behavioral pediatrician with the longest wait time of 3 months. And as I said, the average wait time right now is 12 to 18 months. So this is a pretty expedited access. When we looked at dental, how did we do in improving dental access? 31 of our 42 kids were age eligible for dental care. So they were over 1 and had teeth. And 18 of that 31 kids, or 58%, got their dental care at Children's. And 100% of the children seen at Children's met the statutory requirement of a dental exam scheduled or seen within 8 weeks of removal. We are proud that the KICS Clinic is the first Children's Hospital Colorado ambulatory clinic to have a naloxone distribution program. And we offer universal naloxone distribution to every patient over 12, and every family member who comes can foster biologic family can get a naloxone kit at every appointment at the KICS Clinic. And that program went live December of 2023. So just briefly, year 2, I think we were able to expand to Wednesday mornings. The first year KICS was open, it was just Monday afternoons. We were also able to add another provider. We saw 28 new patients in Q1, which is a 133% increase from year 1, Q1. And we saw 64% of the total number of patients we saw in year 1 in our first quarter. So we are busy and bursting. We continue to have a high retention rate of 84%, and our encounter completion rate increased 325% from year 1. We were fortunate to get some qualitative feedback from families about the clinic. And we asked what worked and what didn't work. And fortunately, overwhelmingly, people were happy with the care they were receiving. Our willingness to listen, our responsiveness, help with transportation. They plan to return to our care. And mostly what they didn't like is that we weren't open enough and we needed better signage, and we've been working on those things. This is the most important part to me because each one of these represents an individual kid that we were able to help, or an individual family, and really highlights the work of all of our team members. We help with school enrollment. We've helped with access to mental and behavioral health services and keeping some of our teenagers out of the emergency rooms. We've been able to help facilitate access to specialty care. We've been able to help simplify and consolidate care for families. We've been able to provide continuity of care across placement changes, which is something that is really important to me. We've been able to help navigate consent challenges to reduce delays in care. We've been able to coordinate with other disciplines, guardian ad litems, respondent parent councils, CASAs. We've been able to do warm handoffs for some of our kids who've transitioned out of state on ICPCs. And our nurse care coordinator has worked tirelessly both with the family and the new specialists and PCPs to ensure that child has a warm handoff across all their care. We've been able to advocate when there's been delays. We've been able to help with resource connection. Our community health navigator has helped a lot of families with all different kinds of needs. And we're really proud that we've been able to start to see some of our families once they've reunified with their children. And we love getting to see them. This is a picture of the team, and I'm happy to take any questions. And really, if you need help or need to know anything, Angie Turbyfill is our social worker, and she's a great first point of contact and knows all things KICS.
Thank you so much, Bird. I think we have time for 1 or 2 questions.
I was just curious what the magic was in expediting the evaluation, the developmental evaluation. It was definitely.
So I think the magic sauce in expedition is relationship building. And we were really fortunate that there was a developmental and behavioral pediatrician who had a special interest in this population. We were able to carve out funding for 10% of her clinical time, that she has a clinic that she can hold for KICS clinic evaluations. And then if they aren't filled by KICS, she can take kids off the general wait list for Dev Peds. So those appointments don't sit open. The template isn't, vacant, which isn't a great thing, but we can make sure that our KICS clinic kids get in fast. So relationship building, I would say.
Sounds like some of your patients want more availability, right? They want more of KICS. So clearly a need here in Arapahoe County. What does the landscape look like in other counties across Colorado around serving children in foster care?
Yeah, so Denver County has the Connections Clinic and the Safe Center, which really, the Connections Clinic is also a medical home model that's housed at the East Side Clinic. And the Safe Center does more of the acute assessments for Denver County. But outside of those two counties, there's not really dedicated clinics to have this kind of wraparound specialized care that I'm aware of.
Right, other questions? Okay. If you want to hear more about the clinic and learn more about Bird recorded a recent charting pediatrics podcast episode. And it's a great episode. And so you can take a listen to that and learn a lot more about Bird's journey and the clinic.
Thank you, Bird.